Everyone, my name's Peter Hibbert. I'm talking to you from AIHI, and this is the AIHI Webinar Series. We'd like to welcome Professor Siri Wiig to this webinar. We're just going to give it about another minute to allow for everyone to connect, and then we will commence. Okay, we might commence. Welcome again, everyone. My name's Peter Hibbert, and I'm hosting this seminar series. And welcome everyone. Before we start, I'd like to acknowledge the traditional custodians of the land on which we're gathered and pay respects to their elders, past and present. I would also extend that respect to all Aboriginal and Torres Strait Islander people here today. And I come to you today from Ghana land. I'd warmly like to welcome a great friend of ours, Professor Siri Wiig, who many of us at AIHI count as a friend, and Siri's a honorary professor at Macquarie and has visited us a couple of times. So essentially, Siri's going to be talking on national healthcare safety investigation bodies, so what and who cares. The topic of her presentation is, we know that adverse events still occur quite regularly in healthcare, and the reasons that these adverse events occur are complex. Improving these relies on improvement at many different levels of the health system, from local to national. Norway and England have established national independent investigation bodies to support learning and improvement, and to do investigations, obviously. So what Siri will be talking about is the rationale, expectations and practice around these two bodies. Siri works at the University of Stavanger and is the Centre Director of SHARE, which is the Centre for Resilience in Healthcare at the University of Stavanger. And her key research interests are resilience in healthcare, patient safety, quality improvement, safety investigations, risk regulation, leadership, and learning in socio-technical systems. And as I said before, Siri is an honorary professor at the Australian Institute of Health Innovation. I'm going to hand over to Siri in a moment. Before we do, you can ask questions using the Q&A function at any time during the presentation. I'll be collating those and managing those during the presentation, and then we'll we'll use those Q&As and present them to Siri at the end of her talk. Her talk will go for about 30 minutes, so we'll have plenty of opportunities to have a discussion. So Siri, I'd like to hand over to you.
Thank you, Peter, and thanks for inviting me to this seminar series. I'm really honored to be here and to present here to you and all my Australian friends, and to the other participants. I would like to share my screen with you. If you could confirm, Peter, that you now see my full screen, I'll be very happy.
Yes, that's great. Thank you.
Thank you very much. And thanks for your introduction. So my background is as a safety scientist, and I've been working on safety in healthcare for 20 years. I've also been part-time working in the Petroleum Safety Authority of Norway, which is a regulatory body for the oil and gas industry. So I've been working both as a researcher, but also as an inspector myself, doing investigations. So it's inspiring for me to share our research and ideas with you on this topic of national healthcare safety investigation bodies, so what and who cares? It's an interesting field, and I've been interested in it for many years. So this is part of my research and our center activities at the share. So here you see some of my colleagues at the Center for Resilience in Healthcare. We are the largest research group in Norway studying quality and safety in healthcare. We have 3 partners, which is the University of Stavanger, it's the Norwegian Air Ambulance, and the Norwegian Science Technology University at Gjøvik. So we are more than 70 researchers in the center, and we have international collaboration worldwide, including Macquarie and a nice group there, and including also 6 adjunct international professors, and Professor Jeffrey Braithwaite is one of our colleagues working with us. So it's really nice to have these kind of seminars now to connect in these times. So before I start, I'll just give you a very quick overview of the Norwegian regulatory system, because I think that is okay for you to know. In Norway, we have mainly state-driven hospitals, and the primary care is provided by the municipalities, with a large degree of freedom for the municipalities to provide nursing home services, home care, and organized general practitioner. So that's kind of the backdrop. And at the national level, we have a Norwegian Board of Health Supervision, which is the national regulatory body. It is there to ensure service provision according to the law. It is focusing on both the individuals and the organizational side of providing safe services with high quality. Most of the activities is going on with the offices of the county governor, which is the regional regulatory body. And we have quite a comprehensive legislation into patient safety and quality, focusing on internal control, demands for safety management systems. And both at the individual and at the organizational level, we have quite comprehensive regulation, I would say. But there is no mandatory accreditation and certification, so that differs perhaps from the Australian system. So this is just a kind of a little backdrop, so you know that there is one major inspectory body or regulatory body doing inspections and handling reports of adverse events. So that is kind of something else that I'm going to talk about today, but this is okay for you to know. So my main talk is about introducing actually national healthcare safety investigation body, independent bodies. So I've been involved in this work for the last 10 years of how to develop this independent investigation board in Norway, similar to my colleague Carl McRae has been involved in England for the establishment of the English version. So I've been working to provide decision makers with information about fundamental safety principles and research, and what is important to do if the purpose is learning only from the investigations. So for me, the aim has been to contribute with information to the decision makers and to try to translate safety knowledge into healthcare policy and practice. So I've been part of the Norwegian Law Commission behind a new law that established a national healthcare safety investigation body in Norway. For me, it started with a newspaper chronicle back in 2010 when I raised my concern about investigation, and they are too focused on individuals in healthcare and blame. And if we want to learn, we have to shift direction of this, and also to listen much more to the patients and the families, and we need to provide a safe space for the healthcare professionals involved. So if you want to learn, you need honest information, and then you cannot be punished for telling people. So this is kind of the backdrop of my engagement, and why I think it's important to provide information about safety and research to the decision makers. So that has been what I've been doing. And the background is that safety in healthcare depends on many factors spanning the entire healthcare system, from the individual healthcare professionals to managers to regulator and the decision makers and policymakers. And we know that adverse events, they will occur, and the reasons are usually complex. It's not simple, it's not straightforward, it's complex. And in order to improve patient safety, we depend on investigating and understanding this complex network of factors at all levels in healthcare, from the individual to the regulatory level. And until we had this new investigation body, we didn't have anybody doing this type of investigation with a mandate. But of course, when talking about investigation, there are numerous of challenges of diverse characters in healthcare, and these relate to several aspects. And one of these is the role of the different investigation bodies and the purpose of their investigations. So I'd like to go into that area a little bit first. And this is kind of maybe a picture how you might think about investigation and how information is fed back to the system after investigation is not necessarily positive for the involved healthcare professionals. And we often see that establishing new procedures and making sure that the sharp end personnel comply to the procedures, get the training they need, that's kind of often the solution that you see coming out. But these different bodies, they have different challenges. If you're looking at the regulatory investigation, which is quite common in Norway, for example, these are investigations to look into if the law was complied, and if not, there can be administrative sanctions against individual healthcare professionals, for example, to get a warning or to lose a license. It can also be against organization sanctions. There can be fines. So if you look into the police, they have a role, they have an important role, all these bodies, and the police, they are looking into to see if anyone can be punished for what they had been doing or not been doing. So that is a big challenge if the purpose is to learn. We have several public inquiries, which has been, for example, quite visible in England with the Mid Staffordshire inquiry, the Bristol case, and you can see that Mid Staffordshire, for example, costed £13 million, I think. And these are ad hoc investigations, so they are also quite expensive. There is not a very good system around them, and they depend on each incident or accident and a kind of a major size. We have also challenges when it comes to the in-house investigation. For example, in a hospital or in a municipality, they can be too narrow, and people lack trust in them because the investigators doing the investigation can be too close to the event. So there are multiple challenges, and many of them lack focus on learning and improvement. And that has been kind of the key for these new national safety investigation bodies. Focus is on learning and improvement, and that's the only main goal, to improve patient safety. If we look a little bit further to the challenges, of more general challenges, not focusing on the national level necessarily, we see that challenges in investigation relates quite a lot to competence, which is often too narrow. We can see investigations that there are the healthcare professional perspectives included, medical perspective, nursing, and then you can also often see a legal perspective included, but we lack focus on, for example, organizational factors, and we also lack focus on the methods part of it, because safety investigation is also about having good control over the methods and have a good competence on methods, and that is often lacking. We also see problems when it comes to independence. It can be too close to the event, those who do the investigations. That contributes to a lack of trust or maybe too narrow perspective. And a key here is also the lack of patient and user involvement. And this has played a key role in the establishment of the Norwegian investigation board that I'm talking about today. Patients and families have experienced terrible adverse events and cover-ups from several bodies, and they didn't find any current body doing the job of learning and improving. So they have been pushing forward another type of investigation body. And this also played a key role with the trust. So if you don't trust investigation or the results, that is a major challenge for learning. And also the system understanding is a major challenge, because too many investigations focus on the sharp end and very close to the clinicians, and they lack attention to decision maker, managers, and regulators, and they don't have necessarily the mandate to look at those stakeholders in the system. So those are kind of key challenges that we need to keep in mind and try to address in a national investigation body. So if you look into the literature on how to understand accidents in healthcare, it is fascinating to see. So here we have an example where one event was investigated by 3 different investigation bodies, and what we could see is that these bodies with different mandates and equipped with different tools and strategies, they looked into the causal factors and deviation from the norm, very close to the event, and the focus was highly on why people didn't follow the procedures, and they kind of assumed that if people followed procedures, this accident wouldn't have happened. And we often see this too narrow understanding of causality, and it's also always interesting to see who are invited to contribute to the investigation. And this is where we can expect national independent investigation bodies to make a difference and to widen up the perspective of investigating accidents in healthcare. So what I'm talking about today is mainly the Norwegian part, but this is also what we see in England, Healthcare Safety Investigation Branch, short to HSIB, and the Norwegian Healthcare Investigation Board called UCOM in Norway. So these are national bodies. HSIB was established in 2017. They started investigations. They didn't have actually the regulation in place. So they established an organization and they started to investigate and have increased the number of investigations, and also have a large focus on maternity investigation that you see on the right hand here on the web page. So it's an organization doing investigations, but it's interesting to see that they started without the legal framework established. So in Norway, we did the other way around. We started with a long process of a national law commission that I was involved in, looking into the field of healthcare and how we could investigate. And we developed a law proposal that was sent to public hearing. And actually, the majority didn't want this law or this body in Norway. However, it was approved by the parliament in 2017, and the organization was set up and to do around 20 investigations a year. And this means around 20 employees working full time. So it was established, this organization, and it started investigating in 2019. And there are some fundamental principles behind these types of independent investigation boards that needs to be in place to succeed. And you see them here: independent, system-wide, multidisciplinary, and learning focused. I'll go a bit more into that. It's modeled here, and it's quite key that these aspect needs to be approached in a holistic way. So you can see there they are linked, being independent, having a system-wide perspective, and being multidisciplinary and learning focused to actually be able to serve the purpose that they are going to deliver on. And if you look into the independent and system-wide aspect here, one can question what is independent and what is not. Independent here means that they are not a part of the system that they are investigating. So in Norway, that means they are actually part of the healthcare system, but they cannot be instructed by the ministry, for example, or by any other bodies. So they are an independent body, but they are funded by the state budget and from the Ministry of Health and Care Services. But it's still not part of the system that they investigate in terms of having a role there. They don't have any sanctioning power. That means that if you provide information to this body, they cannot use that information to sanction you. And for example, if a surgeon was involved in an adverse event and he or she informed the investigation body that he did something wrong or she did something wrong, or anybody else, this information cannot be used and it cannot be transferred to any other bodies that has the power to sanction. And that is kind of a very fundamental aspect of these organizations. So you need to be sure that people can give learning information, honest information, without being punished for it. So if you want to learn, that is a fundamental. And also the sanctioning power is key. So for example, the EUCOM in Norway can get information, but from the different stakeholders. So they can have information from the police or from regulatory bodies, but it's not the other way around. They will not hand over information to those bodies. So people who share information with EUCOM during investigation have the right to not be, that information will not be used against them. And if you look at the system-wide aspect, they can investigate all stakeholders in the healthcare system. That means looking into managers, regulator, policymakers' role in adverse events. And usually there are early warning signs that could be acted upon from higher level stakeholders and maybe should have been acted on, but this hasn't happened. And investigations need to look into these stakeholders' role in adverse events, and that's kind of part of the mandate for these investigation bodies. So that is key, I would say, and a fundamental principle. Also, the learning focus is key, is very much linked to the other ones. So learning is the only purpose, and patient safety improvement. So what these organizations are kind of equipped to do is to focus on system change. How can learning happen from these adverse events? And to do so, we need the multidisciplinary approach and understanding, because adverse events are complex and they need diverse perspectives and methods and competences to be understood. What happened and why it happened, and this network of underlying factors in adverse events. To be able to address those, these body needs to be staffed with competence to understand and ask the right questions. So that is kind of very interesting to see also how these organizations have been staffed and established. So I'll come back to that a little bit later. And when we talk about these national safety investigation boards, independent boards, one can ask when and what to investigate. How should you choose these cases? So in Norway, we have around 1,000 reports of the most severe adverse events coming into the Norwegian Board of Health Supervision. And those reports go directly to the EUCOM as well. So they get the information about adverse events, and they need to choose. In the same way that a regulatory body has to investigate, they have a mandate to investigate all. EUCOM can choose what to investigate, but they get the same information. And from these 1,000 reports, a large proportion of them are deaths, and around 700 of these reports come from hospitals and around 150 from primary care providers. And we know there are underreporting. So from these 1,000, you're going to choose around 20 investigations that you are doing a year. Some of them will be based on those reports. Some investigation will be based on other information. So there are some key questions here. How should you prioritize the limited investigatory resources, and what should a system level investigator investigate, and when should it be initiated? So those are the questions that these organizations have to grapple with. And in Norway, the legal framework specifies some principles and purposes of these. So I thought I would share some of that with you. You see here the purpose of this new investigation body is to improve patient safety and user safety in the health and care services by investigating severe adverse events and other severe conditions. So I'll come back to that, because there are some definitions that I think is key in Norway that is actually included in the law. So you see the law here on the right-hand side, and So key definition of what to investigate is to look into severe adverse events. Is death or severe harm on patient or user when the outcome is unexpected given the foreseeable risk. So there are also always some kind of risk anticipated with expected risk in healthcare, but if it's if it is unexpected, then you should focus on it. And also the key definition of severe condition, that is circumstances or relation that can be assumed to cause severe adverse events. And that is a bit flexible. So that is interesting. And we will see, because the purpose of an investigation is to investigate the course of event, the causal factor, and the causal relationship to contribute to learning and prevention of severe adverse events. So we have many of these in Norway. Here you see a newspaper front page of one of the largest Norwegian newspaper. These are all patients that have been harmed in Norway. So it's terrible to see those people experiences harm, and we need tools to help investigators to look into this. And we have in Norway built in flexibility, because these investigation boards, they decide on their own which adverse events or severe conditions to investigate, the timing of the investigation and the scope, and how it's going to be conducted. And for example, it's been argued that they have flexibility to investigate, for example, series of adverse events or near misses, reorganizing processes, collaboration or lack of between service providers. So one fundamental aspect with these organizations is that they will not take on all types of adverse events. They will have to choose, and they have limited resources, and they will give priority to some of them. And they don't have to make a statement why they didn't go into the other events that they had access to and knew about. So from the 1,000, they don't have to argue why they didn't look into the 990 other cases than the 10 they took on, for example. So some of the keywords, I would say, similar to HSIB, when they choose and when they make decisions on which type of cases to go into, it's about the outcome impact, both on people and services. Can they have some impact based on going into a case? They need to address some kind of systemic risk, wider system risk associated with the event, and also have this type of investigation, will it have a high learning potential? Because they would like to focus on learning in everything they do. So those are kind of keywords for selecting out cases, but it sounds simple, but it's I think that's one of the toughest processes to establish these criteria for choosing what types of events to go into. And one of the other aspects that is key, I would say, in succeeding for these national safety investigation bodies is user involvement. It's highly expected, but it's pretty hard to practice. And we see that, I would say this is a key, because the users and usually the next of kin of the dead patients, they have been able to mobilize resources to push the system change and establishing these types of investigation bodies, both in England and in Norway. So I think user involvement is key to succeed in these types of investigation boards and their practice. And why is involving patient and the family? So you can say patient involvement is sometimes hard because often the patients have died, but involving the family, and it is key because they have different perspectives, and they know a lot about the system, and they can reveal, for example, power conflict, challenges within the organization where the accident happened, that you don't access by just talking to the healthcare professionals or the managers. You need to see the perspectives of the families in these cases as well. And there are different ways of doing this in the international literature, but the most common used way is to interview them in investigations. So it's not unproblematic to involve patient and family investigations. There are challenging aspects, epistemic injustice may occur, whose voice is being heard in the investigation report or in the investigations. Those are important things to look into from the research side as well. But we know that looking into or involving families, patients and families, they provide new information. And we have experienced this in studies in Norway where the regulatory body invited next of kin to patients who died during adverse events to give their perspective on the event. And we could see how that provided investigators, although that was a legal investigation by the regulatory body, I think it has quite a lot of interesting findings to the independent bodies as well. You can see that the next of kin had lots of knowledge about the system and how the system had been acting during the patient journey. And the patient journey is key because you need to know what happened with the patient over time. So the investigators got new information. They got more information about additional stakeholders to involve. And we could see the causal change and understanding of it change based on the information from the next of kin. So you get another perspective of time and the patient and a more in-depth description. So that is very important for these national safety investigation bodies to take in. And when we look into involvement and what we can expect in Norway in terms of involvement investigations and also which is also regulated by the law. So in Norway, the patients, the users, next of kin by law have the right to report adverse events directly to the EUCOM, to be informed about the investigation commencing. They can make a statement about the event, so they should be heard, and they can comment on a draft report based on the information that they have provided. So those are what I would say quite a strong way of involvement on the paper and in the law, but it's still, of course, yet to be seen how this involvement will be facilitated and influenced investigations over time. And I think it should be researched to see how this is being done and the challenges and the barriers and the positive aspects about it, both from the investigator's point of view and from the involved patients. So that is a very interesting aspect of the Norwegian system, I think. So if we try to look what's happened so far, it's been quite a process of establishing a new organization that's been going on. They've been looking into, or they've been dealing with a lot of recruiting people. And that has been fascinating to see. If you look into the webpage, you see the different professional backgrounds from the staff that has been employed. You can see people with philosophy background, psychology, nursing, medicine, legal people. You see journalists, political science, in addition to having also very different experiences over time among staff. So that means that they have recruited, established a new organization. They have so far around 20 employees working full-time, 6 part-time working in the clinical practice more, with a 20% position in EUCOM. They have been hiring more people, but according to the annual reports, around 20 employees. And during this period, if you look into the annual reports, they have been focused a lot on training and methods development. So training of their staff. And this is also about building kind of common ground, because when you look into the principles I talked about earlier about having a multidisciplinary background, that is key, but it's also then challenging, I think, to establish a full new organization with different professional background, and they're supposed to find some common ground and have some common understanding of purpose and how to develop into methods, methodological approaches. So those aspects are very interesting, and I think we see this has been a kind of a research phase for the organization in Norway, and they have been doing a lot to try to train their personnel and to get some common ground. And if you look into the input, how much is reported to EUCOM. By December, it was 1,278 reported events, concerns to EUCOM, and they have a reflection panel established to give input to the board, and that is you can see participants from very different backgrounds, academia, practice field, user representatives, to give input to the EUCOM's kind of both establishment, practice, and to have discussion. So it's fascinating to see how they have been focusing on getting input from different stakeholders to their work to make it relevant and to have a nice relationship with the field. And if we're looking into the results, it is expected that they are going to produce around 20 reports a year. And so far, they have published 4 reports. It's one kind of what you can call a safety alert about securing buildings so people don't fall out of buildings. And then they have produced 3 investigation reports that's published. So I would say they've been working a lot to build relations with stakeholders in the Norwegian healthcare system. So they are independent, but still they have relations with the stakeholders. And I think part of that is also key to have an impact with the results that they are producing. So we see that they have produced these reports and recommendations, and they also produce learning material so that others can use it. And of course, it's yet to be seen how it's being used. And if we look into more of the so what's coming out of it, it's you can see here you see the 3 first reports. 2 of them have actually been translated into English, so you can access their webpage and find the reports and read them. It's also learning material accessed on the webpage. And what I think is also interesting is the explanation of methodological approach and how you can see the user or user voices in the investigation reports. You can see how they use, for example, AxiMap methodology to support their investigations. And but we still don't know if the reports, how they will be adopted, how the learning information will be used, and by whom and why. So I think it's still in an early phase and an early establishment phase, but I think the demands for this organization will increase, and I think the number of reports will be expected to grow. And they have web pages showing investigations ongoing, so I expect more than 3 coming out. But of course, doing these types of investigation in times of Corona is also very challenging, I think. So that is also kind of a methodological challenge to do to deal with in this period. And if you look into who cares, I've been looking into this evolution, I would say, for a while, and it's very obvious that initially there was major resistance to establish EUCOM in Norway, and it was established despite of this. So it was approved by the parliament, the law, but there was major resistance from national policymakers, regulatory bodies, and major resistance. And there was lots of argument that the resources and funding going in here should be used to stronger regulatory investigations. It should be used to more in-house activities instead. So I think there are some stakeholders out there. Sometimes you wonder if they hope the body will fail, but I think it's kind of the resistance has been reduced after it's been started, put into operation. And that's good, I think. We need to give this body a chance to work over time and then evaluate the results and outcome before we judge so hard. And then I think patients and families, they have major expectations for both the results and impact from the EUCOM activities. They were the ones who drove the development of the EUCOM organization and the law. And by doing that, we have seen a lot of changes happen elsewhere in the system as well. We see more patient and user involvement in regulatory activities, for example, than we did before. And if you look into the healthcare professionals, they can expect, they will experience also a new body asking for information, and there is no blame around it. Of course, Norway is a small country, so that can be challenging as well. The patient safety research community is, of course, very interested in the results and findings, and would hope to be able to look into how the results and how it's translated and adopted in a kind of a long-term perspective doing research. And there are some general demands for showing effect, which is kind of interesting. I think it's higher expectation to show effect from this kind of organization compared to, for example, investing more money in regulatory activities. So the demands for showing effect is challenging here. We have implemented a lot of quality and safety improvement measures without knowing the effect, and this is one of the aspects here as well. High expectations for effect, I think. And I think one of the key of here is to see beyond the single events, to look into the severe conditions, patterns, emerging problems, and having the holistic perspective. So the holistic perspective is key and often slips the agenda, I think. And we often see that newspaper journalists are able to find problems, but investigatory bodies are not. So hopefully this organization can look beyond the single events as well. So to summarize, we have short experience in healthcare with these types of investigation bodies, and I think it's key to focus on research. We need that to evaluate both the processes and outcome. But these types of investigation bodies, it integrates learning, safety principles, and the patient perspectives. And it also takes healthcare professionals very seriously and should prevent blame. But of course, this is just one out of many efforts to improve patient safety. So that is, it's important to keep in mind. This is one out of many, and it would be interesting to see the results in a bit longer perspective than we have in Norway at the moment. So just like to say thank you. This is my university, and I'm really happy to have participated. Thank you very much. And I think I'll stop sharing.
Thank you very much, Siri. That was fantastic. Really informative and a really nice view, not just of UConn, but also the history behind it, which is also, you know, really important around the resistance that around setting up such an organisation. I think what I got out of it was those really strong principles that continued to with the themes across your presentation around the independent, system-wide, multi-D learning. But then the other thing that came across almost on every slide was the importance of the patient perspective. So, and you really push that across strongly, and that's a fantastic thing for UConn to really integrate into what they're trying to do. And then the other thing that I got out of it was that all the very, very different skill sets that you've got at the agency, which you rattled off, philosophy and things like that. So I've felt that it was a really interesting point. So thank you. I have some questions, but we also have some questions that from the audience, and thank you, audience, for putting your questions on the Q&A. We'll try and get to them. We've got about 17 minutes. Good colleague of yours, Caroline Cranford, has got a question about that patients and next of kin and also clinicians often suffer greatly from unsatisfactory organisational responses. Okay, so not necessarily the adverse event, but also that response. How do you feel that this helps that reducing that harm associated with essentially a poor organisational response?
Well, we don't have a lot of experience in Norway yet, but I think to be sure that this information cannot be used against you is fundamental, and to have that knowledge. But as I said, Norway is a small country, and that might be a problem in here too, and it's been discussed. But I think this type of investigation is also set up to actually protect the healthcare professionals. So I think that is also a key here. It's set up to get all the kind of information that can shed light on an incident from the different perspectives, and also to make sure that the healthcare professionals are treated or not treated badly afterwards. So it's, but often I think maybe the organizations where they work, they might know about this, and they might have other actions taken against them. But still, I don't think we know enough. And I think that is one of those areas where we should actually investigate from a research point of view. What is the role of these types of bodies also when it comes to handling the internal problems with dealing with the staff?
And a secondary question to that I was going to ask anyway was, you mentioned the resistance to setting up UCOM. What about the clinicians, both prior to its setup? What was their perspective? And also when clinicians are being asked to be involved in who have been involved in adverse events, and they're being asked to be interviewed, how do they respond?
Yeah, I think there was a mixed opinion among the clinicians. I think some see the benefit from it. Others in Norway, they think we have systems in place. We're not maybe as blame oriented as other healthcare systems. So the clinicians, I think, were mixed. If you look into the Doctors Association, they have had some responses to the public hearing that was mixed as well. So and then the other question was, you asked about the clinicians, and then you asked about
when the clinicians, when they're actually involved.
Yeah, when they're invited. Yes.
Yeah.
But that I actually don't know, because
Okay.
I haven't been doing. I haven't been able to ask either the UCOM members that's been involved in these types. So that is also a topic that we need to investigate, actually.
Yeah. Okay. Thank you.
I'm sure they will be able to answer that more than me.
Yeah. And that is an important point. There's a few questions, all of a similar theme. So you've presented a set of principles and processes at national level. Do you think that they can be replicated at hospital or individual health system level, or does this only work at a kind of a national level with a legal framework in place?
Well, I think some of these principles can be adopted into in-house investigations. For example, the multidisciplinary aspect, where you integrate different types of competences in the investigation teams. And when looking into the independence, you can, for example, try to involve the patient and or next of kin, or you can involve people from other departments a bit further away from the where the incident happened. Learning focus can be, of course, be really strong, focused on, and that is also, and the system-wide, yeah, you can look outside your own organization to see what is causing these working conditions here. So I'd say yes, and I've been talking to you, Peter, also about the role of patients, how they can maybe, or next of kin, be involved in investigation, and just by inviting them on board, I think you get a new perspective, and you also perhaps have a stronger focus on the independent part, because it's then a bit more mixed competence and experience in those types of investigation teams. So yes, I think several of these principles can be applied in different areas without the legal framework behind it. But of course, when it comes to the sanctioning part, that is key. So you need then to establish principles in your organization that, yeah, we are just doing this to learn. Of course, sometimes you will come over the bad apple thing, and there are sometimes clinicians that perhaps shouldn't be working there. And that is also an aspect, so we cannot forget that.
No.
And also that's why I say it's not like just doing regulatory inspections, just doing independent inspection, just doing police. I think these are all key factors in healthcare systems to be in place. My opinion, we need different approaches, angles, and ways to deal with these types of investigations.
And just to put a local perspective on that answer, Siri, that Safer Care Victoria have supported their health services to increase the number of independent members and consumers on their, they call them investigation panels, but investigation teams. So the ones that help at health service level. So, and over the last 2 or 3 years, the proportion of investigation teams that have had an independent person, independent meaning someone from outside the health service on the team, and a consumer. So the consumers are running at about 30% of teams have got a consumer on them, and the independent ones are above 50%. So so they've kind of made that shift in terms of some of those principles, which I think is fantastic. And I think that's also a really good research topic to say, well, how does that change the processes and behavior within those teams?
Yeah, sure. And also in Norway, I've been discussing with regulatory bodies and asking what does it mean that the patient or next of kin can report? How does it influence the selection of cases, for example, being investigated? That is also a very interesting topic to see. Does it change the selection of cases or not? So as I said, it's have impact on other areas than the independent investigation one. You also see the user involvement being much stronger in the regulatory investigations and the regulatory body as well.
Okay, so, very good, very good. Yeah, okay. Mark Cantor has asked, you mentioned multidisciplinary involvement of nurses and legal professionals, but I never hear engineers or industrial professionals like, I suppose, and human factors people get invited to participate in such investigations. That does happen sometimes, but maybe Mark's experience it doesn't, and I think it's a very local phenomena. Yet industry has been leading the field of accident investigation for decades. What can we learn from other industries in this space?
Yeah, I think we can learn a lot, and I think it's been inspired by other industries, the principles, the approaches, and you see a strong human factors competence, safety science competence in the EUCOM organization. So that is probably maybe didn't mention it, but that is one of the key competences in that organization. So I think what we can learn from other industries is the focus and interest in safety and investigating and learning from adverse events, and also to have the multidisciplinary competence, addressing the problems, and having a key organizations doing the job. So having people actually paid to do these investigations, and I think that is key. And it's also doing justice to the patients, I think, because it's kind of, for me, I think it's also important to use, it's kind of to choose to take them seriously. Having experienced patient harm, losing a relative, it's terrible, and they need some kind of answers. So the problem in Norway might be that not every case can be investigated like this, and they might have expected that each case should be like investigated, but that is of course a political decision. How much funding do you put into these investigation bodies? Norway has funded around 20 investigations a year. Maybe it could be more, maybe less. So we will see. It'll be interesting in a 5 years perspective to evaluate this and see what could be done by these resources, and what's the kind of effects and results in the in the practice field and at the policy level.
Okay, and thank you. And that's a really nice segue. And you mentioned this right at the end of your presentation, to think about in 5 years' time, assuming then you're doing 20 a year, What does success look like for this at an organisational level and a health system level?
Well, that is a good question. I think if I had the answer, I would be rich. So it's I don't know, but for me, I think it's important that we establish an organization that has trustworthy methods, that they are transparent, and that they are competent, doing a good job on the investigation methods side. So I think that is one of the keys, and success in a 5 years time would be that this organization is really listened to and can be a critical voice. So I don't think it should be too close relationship with the practice field. It should be able to be a critical voice. Still, I think it needs to be considered as a partner providing with good learning information. So it's not just a report going into a web page. There needs to be set up a structure in the healthcare services to adopt this kind of learning information. And that can be done in different ways, I think. So you have to use different means, not just reports. So you can see they produce learning material. Maybe they could produce short films to have discussion and reflection. And then I also expect some higher level influence on maybe regulatory changes coming out of this. So it's been criticized that, well, we don't have there's not a big stick behind the recommendations, so you can't punish anyone if you don't integrate the suggestions or recommendations. So I think that is part of the picture here. So in a 5 years time, it will be interesting to see how much it is listened to and how much we see this in the public debate. We see the Norwegian Board of Investigation Board in Transport. It's highly visible in the newspapers when there are those big events coming out. So if you have 3, 4, 5 investigations, they should be on the front line of the newspaper, maybe. So to be visible.
Yeah, I wonder when, and I'm not sure if this has happened in the UK either, but because they've produced a few more reports, but whether when you're looking at that, you're hoping these investigations are robust and high quality, whether that has a learning or a trickle-down effect to the investigations that are happening at the health service level, whether they can indirectly learn from, not doing the same level of investigation, but, just saying, this is the methods that this organisation at a national level are using. And I wonder if that has a trickle-down effect.
Yeah, I think that is a very good point, and to have an interaction and to share information about learning methods or investigation method and learn across system level. I think that is hopefully going to happen as well. So that there will be maybe not necessarily collaboration, but to learn from each other. I think it's also fundamental. Even though this is an independent organization, the principles and the practices can be shared. And hopefully we see some change in the way they investigate in-house as well.
In
hospital or in municipalities. Sorry.
Yeah, no, sorry, I interrupted you. So I was looking at questions and listening to you at the same time. And Carl Halsey's got a similar kind of question about: do you expect the approaches and techniques will be taken up by more local investigation? So I think that's
I hope we can see that. It would be interesting to see. It's also I would also say this is a good research question, and maybe also to challenge these organizations on this. How can you translate your methods to operationalized in local level investigations?
Yes. Just looking at other questions. One more, which is, because we've only got 1 minute, which is really about that investigations are not intended to be therapeutic processes for patients and providers, but can they actually have a therapeutic approach if they're done well? or affect if
Oh,
they've done well.
yeah, and so what we could see in our study on involving next of kin, they argued that they had a therapeutic effect as well. So because finally somebody listened to them and they were allowed to also have information explained to them about complex medical information that is not easy to understand, and also to be able to ask the questions and get responses and also to tell their own story. So of course it's emotionally challenging to be involved sometimes, and it should be voluntarily, but it also had a therapeutic effect for some of those participants that we interviewed. Of course,
Yeah,
that
right.
was not a big study, but I think set up in a good way with professionals doing the job, having empathy and a good connection with them. I think that is very good, and also a kind of not necessarily the purpose, but it could be a key effect.
Yeah. Okay, thank you. Siri, we're going to leave it there. We've got lots of other comments and questions, a lot about patient involvement and that, for want of a better word, that therapeutic effect. If the investigation is done well with those principles and with the patient right in the centre. Daryl's saying it's good that you're not relying on domain expertise solely, but you have that multi-deep perspective. And David said, thank you very much. That was an inspiring start to the day. So,
but I could see
David,
Daryl asking about these reports are available. They are available,
yeah, they
and
are
some of them
available.
have actually been translated into English, and I can share the link with you.
Yeah. So I didn't answer
Yeah.
that because I thought that that had been done.
Yep.
So look, Siri, thank you very much. You also got up at 5:30 a.m. because you started. It is now, I think, 7:30 a.m. in Norway. So thank you very much for getting up so early and doing the talk. From the questions and from the comments we've had, it's a really interesting topic for people who have been involved in patient safety for a long time, both not just at the national level, which is what you were presenting for, but some of the implications and the principles that can be embedded more at the local level. And I think that's really important as well. But so thank you very much. It was really informative, and thanks also to the questions that everyone put forward and to your answers. So we look forward to the next seminar, which is on the 19th of May. So Associate Professor Fiona Shand is the Head of Suicide Prevention Research at the Black Dog Institute, and also the Research Director of Lifespan Suicide Prevention. And Fiona's topic is suicide prevention, an integrated approach to meeting community needs. Booking details will be available soon. Everyone who's on the email on the email address thing will receive a notification that the seminar is occurring. So thanks very much, everyone, for your participation, and thanks, Siri, and enjoy the rest of your day. Thanks, folks.
Thank you. Thank you for having me. Bye.
See ya.